Would you like to give us a little bit of your history regarding eating disorders and your experience with them? You told me it's been about 8 years that you worked alongside eating disorder patients. That's almost a decade. What
Mm-hmm,
type of
mm-hmm,
experience have you encountered that led you to staying in that field?
mm-hmm. Sure. So I worked as a registered nurse first on an inpatient psychiatric unit that the primary population was patients with eating disorders. And we had patients anywhere from, I think the youngest was probably 3 years old, all the way to 17. And then once they hit 18, they would need to go to an adult facility. But I started as an RN and I went to graduate school, and then I was a nurse practitioner for that unit. And so, like I said, it was a total of 8 years. I then worked outpatient in a intensive outpatient program, and they also had partial hospitalization. So that was with teens and adults. And then as a consult liaison, psychiatric nurse practitioner, I worked some cases the at UMC here. Whenever patients would come in and they had eating disorders and needed assessments, I would provide that and then establish what level of care they needed, and would help them get there.
When it comes to eating disorders, have you ever worked with anybody as an adult dealing with an eating disorder, or did you mainly focus with the adolescent young community?
The majority of my experience was with the child and adolescent population. But like I said, I did work for about a year in a partial hospitalization and intensive outpatient program it was adolescents and adults. And then the patients that I saw at UMC were adults.
When it comes to 8 years is technology has advanced, the culture has changed.
Mm-hmm.
Eating disorders were first seen as a Western issue. Do you
Mm-hmm.
believe that due to social media and all these body checking videos going viral, do you think that influenced eating disorders becoming an ethnic problem instead of just a Western issue?
That's an interesting question. And so when I started with this population, it was during the kind of heroin chic phase where like Kate Moss was a model, and
Mm-hmm.
Thin was really in and preferred. And so that's what we saw in magazines. And so I think that, it was seen at that time primarily as a disorder of, or it was known as more of a disorder of affluence. So if you have access to food, then you have the ability to restrict, or the luxury to restrict. Whereas if somebody has food insecurity, they don't have that luxury, right? Or if it's a luxury, I don't know, that's probably a bad way to say it. They don't have that option. But I'll say with the population that I saw, it wasn't just affluent, um, um, teens and children and adults. It was all across the board. Now, I will say with the patients who stayed long term, they ended up being those that were more affluent because they had the means, because eating disorder treatment is very expensive, and it's a chronic it's a chronic treatment, meaning that most inpatient stays are a week, maybe 2 weeks, and these patients are in the hospital for months and sometimes years. So they have to be able to afford that treatment.
I've seen quite a few documentaries when it comes to eating disorder treatment, and a lot of these people claim that, oh, in 6 months you can fix this issue. In 6 months, somebody can be cured, but in my opinion, an eating disorder is a lifelong issue that follows you from your teenage years to adulthood. What are some of
Mm-hmm.
these what's some of the patterns that will stick around for somebody that grows up with an eating disorder?
Mm-hmm. So there are some patterns that we do see. A lot of times it's children or adolescents that are placed in roles that are more parentified than maybe their parents aren't around a lot, or their parents have their own chronic illnesses, be it mental illness or physical illness, um, substance use disorders, where this kid has or adolescent has had to step up and take on a more adult role. And there are also usually family dynamics where this child is very pleasing. So, and this is more with you talked about restricting behaviors. This is
Mm-hmm.
more with somebody who has restricting behaviors. So a lot of times it's a more kind of type A
Mm-hmm.
personality, very pleasing, wants to do well, you know, um, and so those aren't patterns. Those are personality characteristics. They're not something we can treat with a medicine,
Mm-hmm.
and they're patterns that have been established over a long period of time, meaning that, you know, from their family of origin, that's how they grew up, that's what they know. And so treatment is not only about um, treating that individual, it's really about treating the family. It's really not possible for the person to get better unless the entire family is involved in treatment. So that's one of the things that I've seen as far as patterns go are family dynamic issues, parentified kids, kids who are pleasers, or adults even who continue to be pleasers. They also are many times internalizers, meaning that they don't talk about their feelings. They suppress their feelings, or they push them down, and you know, put on a happy face. Right? For some reason, it's not okay to talk about feelings in their family. It's not okay to you know, push back. Right? And by their nature, they're pleasing. So yeah.
One thing I've noticed with people that I know have restrictive eating disorders is that they're very, especially the women, I don't know
Mm-hmm.
many men with restrictive eating disorders because it does target the women more, is that they're very self critical, but they're also very high achieving. These women
Mm-hmm.
have degrees and they aspire to be more. Do you believe
Sure.
it? The eating disorder is somewhat of a control issue?
Uh, yes, I definitely see it being more as you know, there's things within our locus of control and things that are outside of our locus of control, and many times the person who has an eating disorder struggling with that is trying to manage um, things that are outside their locus of control with their eating behaviors, which it doesn't, I know it doesn't make sense,
It,
but it, you know, there's chaos outside of my life. There's nothing I can really control. So this is the one thing that I can control. Um, and so, and then it just becomes habit, a pattern. There's also, you know, the idea that, or the theory that there are endorphins and endogenous opioids that um, are released when somebody's starving. So there could be some you know, positive um, reinforcement for people who are starving. And I know you had talked to, you know, mainly about restricting, but that's also with purging. People talk about kind of a relief or being relaxed after they've purged. And so again, it's thought that there's a neurochemical reaction why there's a reward associated with these behaviors.
talking about neurochemical reactions, in the early 2000s, a lot of people believed that you could treat some of the symptoms of an eating disorder that are in comorbidity, like depression and anxiety, with medication. Though with all the nutritional deficiencies, do you really believe that's a healthy approach for them?
So the way I always practiced and the way I understood things was that you can't really assess somebody for depression and anxiety when they're severely malnourished, because they don't. I've seen people who look almost delirious because they're so their electrolytes are so um, um, deficient, and that have to be in the ICU. And really, at that point, your body is focusing on being able to breathe, to blink. There's very little things that your body is using calories for at that point, and cognition is not going to be real high on the list. So for that reason, somebody having gone through the process of refeeding and being at a more stable point. I mean, not at their healthy weight, but closer to it would be a more appropriate time to assess for depression and anxiety, which absolutely they are comorbid frequently. However, those medications aren't going to, and in fact, it's evidence based. There are no medicines that are helpful for anorexia nervosa. Bulimia nervosa, fluoxetine is indicated and can be helpful. But for anorexia nervosa, there's nothing that's helpful other than nutrition and intense individual, family, and group psychotherapy.
So the best treatment approaches would be CBT, cognitive dissonance, and family therapy. Okay.
Yes.
So you said your youngest patient was about 3 years old?
Mm-hmm.
3 years old. Wow, I've never heard about that before.
And that was more, so there are eating disorders that are not, I mean, there are ones outside of anorexia nervosa and bulimia nervosa. So there's avoidant restrictive food, and then also conversion disorder, where sometimes people will feel like they have something, in their throat. And it's more anxiety related. A lot of times it's trauma related. Something bad happened to them that shouldn't have happened to them, and so as a result, they feel like they can't eat. So that's kids, that young. I think I'm trying to think. The earliest patient with like anorexia nervosa was probably like 9. It's usually when kids start to develop their secondary sex characteristics, and if you look at it from a psychoanalytic perspective, some people will look at it as trying to, the person subconsciously trying to avoid puberty and trying to avoid becoming that next stage because they want to remain childlike. So they actually lose, so much weight that they no longer have a menstrual period. They don't have breasts. They start to look very childlike as a result of their malnourishment. So, again, that's a more psychoanalytic perspective, but interesting nonetheless.
Would you like to give us an example of a case where no treatment approaches worked and you had to resort to outside another type of help?
Well, because I worked inpatient for the most part, we were the we were like kind of the last effort,
resort,
even from residential treatment, because residential, if the if the person was not medically stable, they would send them to us. So I worked on a med psych unit so we had patients who weren't stable. They may have been in cardiology or ICU before they came to us, but they would still come with IVs and feeding tubes and in wheelchairs, because they would need to be on such restricted status. I can tell you about, I've got lots of stories. I I can tell you that it's a really insidious disorder, and that sometimes families don't even see that it's happening.
Until it's too
And
late.
so I had one case, and it was actually a male. So a 14-year-old male who came in for an evaluation sent by his primary care doctor for evaluation of level of care and just some help. And he actually had a BMI of 13, which is probably, I mean, that's the lowest I've ever seen. He was emaciated. He was very slow. His slow cognition was incredibly slow. So we call it psychomotor retardation. Like, he even moved slow. Everything was slow. His mother answered most of the questions on his evaluation, just because he didn't have the cognitive ability to answer. And of course, he needed inpatient. We needed to get him assessed to see if he needed to go to cardiology or, the ICU. But the mother was very concerned because he had an orchestra concert the next night, and he was first chair in whatever, instrument he played. And so could we delay this until Monday so he could go to his, his choir or his orchestra concert? And I see her face, and and that's
What? I can't believe that.
Yeah. We, knowing how insidious this is and the family dynamics that are associated with these disorders, we had to be careful in how we worked with this mom, because we don't involuntarily admit children. Even if you go to a judge, we'll get CPS involved, but an adult, you can involuntarily admit them, but kids, you can't. So we had to really work with the mom to help her to see how sick he was. And at one point I said, I don't even want him to walk out to the parking garage. I said, I'm worried about him, losing consciousness just walking to the parking garage from here. So I don't even feel safe letting him leave here to go home to pack.
Talking about my phase, what was her phase? How did she react? Did she seem very avoidant at first? And
yeah, at first she kind of was, she made lots of excuses, and he's been like this for a while, and he's fine, and it's just this one thing, and we'll we won't have him walk very far, and kind of trying to bargain. And so I actually pulled in the psychiatrist because I was so concerned, and the psychiatrist came in and started talking about caskets, and I don't know what kind of I mean, she just went full.
She went all in, yeah. No
Yeah,
sugarcoating. You couldn't
like,
sugarcoat it anymore at that point.
No. Like, he was about to die, and the mother just couldn't. She was so deep in denial, and so focused on other things. She eventually reluctantly, allowed him to stay, and we admitted him. And once she saw the objective information from his lab values, his cardiology consult, and those sort of things, she was, once they can link it to things like heart and and kidneys, then they would see that it was more serious. It just being a psychiatric issue didn't seem.
The stigma
important.
around mental disorders is one of the huge issues why there's no treatment.
Absolutely.
And why there's shame, why people don't want to admit it.
Yes, for sure. Yeah. Mm-hmm.
Did this 14-year-old boy have any irreversible damages to any of his organs after this point?
So that's the good news, is that when they are young, and we can catch it when they're young, typically things can reverse. So the thing that we worry most about is their cardiac status. They'll have aortic root dilatation, um, and you know, they're just cardiac wise. We worry about that with refeeding, and them getting hydrated and nourished again. Those things will typically resolve. Sometimes they'll have some mitral valve prolapse that might stick around for a while, but even that can resolve. Um, so so that's the good news. Now, as they get older and the more or longer and more chronic they have these disorders, um, and whatever compensatory mechanisms they're using, like for example, if they're using a lot of laxatives, um, they can have a prolapsed rectum, which can be very problematic. Um, they can develop esophageal varices from vomiting. So there are things that with repeated, long term, that they can really develop some major issues that we'll see in adults.
In your last years of working with eating disorder patients, did you see a pattern of substance abuse within
And
the
they
adolescent community?
oftentimes, yeah, and so many times we would see uh, more what I would see, because we didn't treat substance use disorder on our unit, so they wouldn't come to us if that was one of their major, like if they needed detox or something. But and knowing what happened to several patients, many of them developed substance use disorders as they got older and as they became adults. And so a lot of nicotine um, abuse, they get addicted to smoking cigarettes. Caffeine was a big one. And this is just, massive amounts of caffeine in a day. And those are ones that you probably don't typically think of, so that's why I include them. But then, of course, alcohol use disorder.
That's actually something I've seen a lot when it comes to older women I know that battled eating disorders in the past. They'll drink
Yeah.
5, 6 cups of coffee, all
Yes.
dark, no creamer, no sugar.
Yes. Yeah. Yep. It's very common.
And it leads
Yeah,
to
I had a patient who used to go. There was a Starbucks at the hospital, and she had an NG tube, and she would go and she would get a cafe Americano, a venti, and like I don't know how many shots of espresso in it, and this was when she was on the medical floor before she came to us, because when she was with us she couldn't do this, but she would be on the medical floor, and so she'd get it and she'd pour it into her NG bag, her NG feeds. So she'd be getting the caffeine. I mean, until we found out she was doing it, but she would also order diet pills to the ICU. So she was very savvy.
very smart. See, they're
Yeah.
tactful
Oh yeah.
and they
Very
have
smart.
very smart. So
Mm-hmm.
when
Very
I
smart. Smarter than us.
smarter than us, how long did it
Yeah.
took y'all to catch her doing that? Did something happen to her?
Um, um, she, I mean, she was in the ICU a lot
Mm-hmm.
for different reasons. She had many suicide attempts, and she did end up dying by suicide when she was about 26, I think. Which she just was so smart and creative, and it was really hard to hear that, because she had I think a special place in all of our hearts, but she was um, just very, very ill for many years.
When it comes to severe cases like those where there's no getting better, well, what type of background did those people have? Did she have a history in her family of eating disorders?
So that's a good question. Her mom actually had an eating disorder, and her mom had multiple suicide attempts, um, and they were a very affluent family. And when I talk about like not like feelings not being okay, or pushing things under the rug. One time I went to see her in the ICU, and she was intubated. You know, she had the tube in her mouth, and her mom welcomed me to her room like I was walking into their house. You know, welcome, welcome. You know, just come sit down. And the patient mouthed around her ET tube, her endotracheal tube. She said, "I like your shoes." So she was like focused on my shoes and welcoming to me to the room. You know, her mom was welcoming to the room. They just did not have the ability to talk about things that were really challenging that were happening in their family and in their lives. And there was just a tremendous, um, there was just denial.
Denial. Yeah.
Yeah. Mm-hmm.
Do you believe there's biological factors that contribute to somebody developing a severe eating disorder that leads to an outcome like suicide?
Um, I would think the chronicity of it. I mean, I'm sure there's biological factors. I don't know if we know exactly genetically. Um, you know, I'm sure there's researchers that are smarter than me that are looking into that. We don't know a whole lot about them, but we do absolutely see that it can run in families, and whether or not that's, I always say it's like the perfect storm with a lot of things. So you'll see somebody, uh, you know, they'll observe learned behavior, like,
Observational
you know,
conditioning from the family
yes,
members.
yes, um, yeah, and so that's how you do it. You know, you sit at dinner and you eat, you know, a fourth of your plate, you know, and you drink three glasses of water before you eat, and then three glasses of water afterwards, and you know, so they'll learn behaviors like that, and then also, like I said, those patterns of, um, you know, not talking about feelings honestly, um, whether it be, you know, culturally not appropriate to talk about feelings, or just patterns in the family, which is also common as well. So, and yeah, like I said, it's like the perfect storm. There's lots of variables that add up that result in this person using these mechanisms to modulate their emotions.
Well, thank you, Mrs. Field. It was very nice interviewing you, and this
Yeah,
interview will help me a lot with my assignment.
great,
Yes,
great.
I may come back for another interview depending on the
Yeah,
requirements, so you may hear
of
from me
course.
soon.
Totally fine.
Thank
It's a
you.
good time.
Have a great
Okay.
day.
Thank you. You had great questions too. All right. I enjoyed it. Bye bye.